Good morning or early afternoon, ladies and gentlemen. It's a great honor to chair this session and introduce speakers who need no introduction. We'll have pro-con on control of severe hypercapnia with ECCO2R in severe Ards. And our speakers, the first speaker will be John Marini, who's con. Each speaker will have about 10 minutes exposure, and then we'll try to discuss and get into conclusion or not. John, please.
Thank you very much. I'm starting on the con side of this argument, and I must say, taking this part of the debate was not my idea, in the sense that there are nuances to what we're going to present that we've got to strike a right balance at the end of it. There are clear indications to target a lower carbon dioxide level, to stabilize the deteriorating ventilation in a patient with a realistic possibility of survival, and the inability to provide safe ventilation by other means. Compromised compensatory cardiovascular response to hypercapnic acidosis. In other words, hypercapnic acidosis has an unusually threatening potential for the patient, and you want to lower CO2. And intracranial hypertension and elevated PaCO2 is not a good combination. You might want to do that. Now, if you're technically competent in providing extracorporeal CO2 removal and nothing else is working, I don't think I have any argument with that. And you need to reduce the PCO2. But there's a flip side to hypercapnia. And the possible benefits of modest hypercapnia, I'm not talking about astronomically high levels, but improved efficiency of CO2 elimination per breath. Each breath that you exhale exhales more CO2 if your PCO2 is high. May mean that you have reduced stretch and power requirements. CO2 may have anti-inflammatory effects. It may reduce microvascular permeability, reduce histologic damage in experimental studies, reduce apoptosis, and cause a rightward shift of the hemoglobin dissociation curve for improved oxygen delivery to the periphery. When you're hypercarbic and have those advantages, there are some factors that promote tolerance. A maintained PaO2 is essential, adequate hemoglobin, and a preserved cardiac output. And that means an intact adrenergic and reflex responses and no beta blockade. These are things that are important for maintained oxygen delivery. No ischemia. Gradual buildup of PaCO2, and this is very important, not rapidly, but slowly building up to a PCO2 that is tolerable. And no limiting comorbidities for this. Now, when I was in Seattle, I knew Ralph Potkin and Eric Svensson, who's still there. They had a patient who came in with 4 to 6 hours of outpatient surgery. He was not intubated or ventilated. And he came in with a PaCO2 level reported at 375 millimeters of mercury. 375. And what that tells us is that even extreme levels of PCO2, if you get there slowly, can be tolerated. He recovered without any deficit at all. So let's not be too afraid of the PCO2 itself or even the acidosis, which was 6.6. In somebody who doesn't have a predisposed heart, cardiovascular collapse, whatever, it may be tolerated quite well. The reasons to consider eliminating CO2 by extracorporeal support in the ARDS: to offset metabolic acidosis, ongoing for another reason, to prevent or manage right ventricular failure, to reduce ventilation power and villi risk, reduce the tidal volume, plateau pressure, driving pressure, minute ventilation. All of those things are conceivable and likely to be accomplished by eliminating CO2 by extracorporeal support. But the goal of tidal volume reduction can be met in most ARDS patients without extracorporeal CO2 removal. And Dr. Richard, who's here at the conference, published a nice study showing that there's feasibility and safety of ultra-low tidal volume ventilation without extracorporeal circulation. And I won't go into the details of the study, but basically saying that you can do it without extracorporeal CO2 removal. Mechanical stress and power, reducing the oxygen, the oxygen consumption and the CO2 production will reduce the minute ventilation through the lung, through the native lung, and that lower minute ventilation will lower power per minute. But transpulmonary stress in ARDS may not respond to minute ventilation and total power reduction because patients still take those strong, stressful breaths. Even though the PCO2 comes down, your minute ventilation requirement comes down, the tidal volume may not be a piece of that. The tidal volume and the stress may be accentuated. And the strain threshold for injury must also be crossed when you think about power. So the fact that you've lowered minute ventilation is instrumental in lowering power, but remember, the Villi risk is also dependent on the strain threshold being too much. So there's two things to consider here, and it's not automatic that if you reduce the minute ventilation requirement and reduce power, that you're going to protect the lung even further. There needs to be a consideration of a pressure threshold for damaging energy. When you think about the energy per cycle and the frequency time, the energy per cycle is power per minute. Remember that if you lower the power, you must also lower the amount of time that you're exceeding a threshold pressure. There's old data that suggests that the lower you go with plateau pressure, the lower the mortality is in the populations that have been analyzed in these randomized controlled trials. This is very misleading, I think. Is opting for a lower tidal volume really better for all patients? No matter if you have 6, is 4 better? Is 3 better than 4? I don't think there's a good answer for it, but there's a very nice paper from Ewan Gallagher, who's here at the conference, demonstrating that lowering the tidal volume below 8, 7, 6, 5, 4, actually it has a negative effect on the odds of death. Whether they're linked or not, I'm not sure, but you may not have a benefit if you go much below 6. Only the very severely affected patients are helped by using moderately low tidal volumes, the same paper. Now, precautions regarding oxygenation with extracorporeal CO2 removal have already been mentioned earlier today. Ventilation perfusion alterations in the lung may mean that you may need to increase the FiO2 when you use the extracorporeal CO2 removal. And the reduced mean airway pressure that you get when you drop the minute ventilation requirement may mean that you have to supplement PEEP under those circumstances with uncertain effects on hemodynamics. Our first mandate is to not hurt the patient, and the risks and complications of extracorporeal CO2 removal, which does require, at the present time anyway, anticoagulation, are vascular, mechanical, and systemic. And the worst and the most dreaded, of course, is intracerebral hemorrhage, which happens, unfortunately, too often. The clinical trials experience has been disappointing with ultra-low tidal volume ventilation. I think you know this paper by Thomas Bein and colleagues. Nicely done study indicated that maybe the severely ill patients came off the ventilator earlier, but the survival benefit was negligible in that study. This is from the REST trial, which to my knowledge hasn't been published yet. It's a much larger study that was terminated for futility and practicality. The standard care being standard tidal volume 6 ml per kilogram, et cetera. And the outcomes being all-cause mortality and a number of secondary outcomes. The results, in a nutshell, it didn't do any good in the 90-something patients that they entered. Early stoppage for futility and feasibility. No benefit in any subgroup. This poor fisherman finds very little fish when they do the subgroup analysis, and basically it's been abandoned, possibly because everybody was already being lung protected under those circumstances. We can talk more about that in the discussion. The safety certainly was not on the side of doing extracorporeal CO2 removal. There was a lot more adverse events in the patients receiving it. So what now? No difference in primary outcome, worse secondary outcomes in adverse events despite reduction in minute ventilation intensity with extracorporeal CO2 removal. Does not support the routine use in the clinical setting. Given the potential for adverse events, do we really need it to reduce mechanical ventilation intensity? Should we go back to the drawing board? Well, sometimes we need to think. Extracorporeal CO2 removal, should we rest after the REST trial, which sort of puts the nail on the coffin right now? And the answer is, don't just do something because you can. Stand there and think about what you're doing wrong, and as this laborer is doing. Why not use extracorporeal CO2 removal in ARDS? Who really benefits? Only patients receiving inappropriate tidal volumes, driving pressures are at villi risk. CO2 removal does not reliably lower transpulmonary pressures, and when it does, higher PEEP is needed to avert atelectasis. Oxygenation benefits are insignificant. High flow extracorporeal alters the lung VQ, resulting in hypoxemia. Low flow extracorporeal CO2 removal requires systemic anticoagulation. Complication rates may be high in non-elite centers. No mortality benefit in multiple trials, and the cost to risk benefit ratio is high. So should we give up? And the answer is never give up. This technology is still in development, and the idea is still very much an exciting one, and I think my competitor here will put that issue to rest. Never give up. And thank you for your attention.
Thank you very much, and please, Piqueron, Lausanne, Swiss, please, your opinions.
Good afternoon, ladies and gentlemen. I'm happy to be here to discuss this very controversial topic. And as my colleague, I'm not totally in line with what I'm explaining here, and I think that some nuance are needed. My conflicts of interest are here. Nothing is related to this presentation. This slide, just to be clear on what we are talking about. Extracorporeal CO2 removal that is currently used is the veno-venous technique with a low flow pump, lower than for ECMO. And the idea is to use a membrane and fresh gas flow to take CO2 out of the blood and to reduce mechanical ventilation injuries or related injuries. And why is this interesting in ARDS? ARDS story starts, as you know, in 1967 with the description of the syndrome. At that time, the idea was to normalize PaCO2 and oxygenation, even if for that, high volumes and high pressure were required. At that time, mortality was very high, 70%. Then later, the concept of ventilator-induced lung injury was recognized, and we moved to more gentle ventilation. Lower tidal volume, lower plateau pressure, enough PEEP. And we said, okay, slight increase in PaCO2, maybe even higher increase in PaCO2 is not a problem. And in parallel to this new strategy, mortality decreased, for sure. And the current recommendations are based on that for ARDS. Deliver a tidal volume of 6 milliliters per kilo for the French Society of Intensive Care, or between 4 and 8 for the American recommendations. Target plateau pressure lower than 30, and use enough PEEP. But we all know that ARDS is a very heterogeneous syndrome, and that our ARDS patients have very heterogeneous lungs. Those lungs are only partially aerated, and the baby lung size, the part of the lung that is aerated, vary a lot from one patient to another. Then probably 6 milliliters per kilo for everyone is not the right answer. And basically, the idea is to deliver tidal volume according to the size of the aerated lung, of the baby lung. And practically, this leads to the driving pressure concept. The driving pressure concept is normalizing tidal volume to the compliance of the respiratory system. As you know, we can measure the compliance of the respiratory system, tidal volume divided by plateau pressure minus total PEEP. And this difference, plateau pressure minus total PEEP, is the driving pressure. And if you write the equation in the opposite way, then you have driving pressure equals tidal volume divided by the compliance of the respiratory system. And that means that when you target a driving pressure, you use a tidal volume that is adapted to the aerated lung of your patient. Then when you target your driving pressure at 15 or 14, you use the correct tidal volume for your patient. And this concept has been shown as correlated with mortality. Amato and collaborators have shown that a higher driving pressure is associated with higher mortality. This was also found in the lung-safe observational study, with a cutoff between 14 and 15, depending on the studies. And probably even more interestingly, you can see here in the data from Amato, on the right part of the slide, that the lower the driving pressure, the better. Then basically, you should decrease your driving pressure lower than 14 to improve your patient's outcome. Okay, but to do that, you have to reduce tidal volume. And if you reduce tidal volume, then you decrease minute ventilation. And if you decrease minute ventilation, then you increase PaCO2 and you decrease pH. Richard and colleagues have tested this strategy of lowering tidal volumes to lower the driving pressure without using ECCO. John Marini has already shown this study before. In 35 patients with PF ratio under 150, all with ARDS, and they tried to reduce tidal volume up to 4 milliliters by kilo while maintaining a plateau pressure under 30 and a pH above 70.2. And what did they find? They find that in 2/3 of patients, it was possible, without ECCO, to deliver a tidal volume around 4 at day 2 of the study. But in 1/3 of patients, because of pH or PaCO2, it was not possible. Then the strategy could not be applied to all the ARDS patients included in the study. And for the 2/3 of patients for whom it was possible to reduce tidal volume, you can see in the middle that driving pressure was lower. But even in the 2/3 of patients for whom the strategy was possible, there were problems. They had severe acidosis in 11 patients, 1/3 of the patients. Then severe acidosis was the price to pay in 1/3 of the patients. It's quite a lot. 2 patients in the study developed acute cor pulmonale. And there was a clear trend in increase of the right ventricular over left ventricle ratio measured by echocardiography. Then the strategy was not innocent for the right heart. And severe hypercapnia is not very good. It increases intracranial pressure. It decreases myocardial contractility. It decreases renal blood flow. It probably increases the endogenous catecholamine release. And probably much more importantly for our LDS patients, it increases pulmonary hypertension and is dangerous for the right ventricle. Then we have to manage this problem of hypercapnia and acidosis. And for that, we have ECCO2R. And basically, the technique is not so invasive. It requires a veno-venous cannula or catheters. They are relatively small compared to ECMO catheters. And we put catheters in the vein nearly every day in our ICU. It requires anticoagulation. This also is not very specific of ECCO2R in our ICU. And there are technical issues, for sure, with the system, in particular circuit clotting, but this can be improved by improvement in the technology. I would like to show the results of this study, which is the SUPERNOVA trial, which was the feasibility study on ECCO2R, published 2 years ago now. Then the idea was to use tidal volume of 4 and plateau pressure lower than 25. Then it was an ultra-protective ventilation strategy, and the patients were put under ECMO. The primary endpoint was to look whether it was possible to achieve this ultra-protective ventilation while keeping pH above 7.3. 95 patients were included. ECCO2R was used during a median of 5 days, and the authors found that 78% at 8 hours and 82% at 24 hours achieved ultra-protective settings. Then it was efficient to deliver ultra-protective ventilation. 73% of those patients were alive at day 28 and 62 at hospital discharge, which are not bad results for severe ARDS patients. Then the authors concluded that the use of ECCO2R to facilitate ultra-protective ventilation was feasible. If we look more at the physiology data of this study, you have here the effect of using the ultra-protective ventilatory strategy associated with ECMO, and you see that you have a gain in plateau pressure, in respiratory rate, in tidal volume. Then you definitely have more protective ventilation. But the price to pay was quite high, as there were complications in 39% of patients, which is quite a lot. And definitely, the technique has to be improved before being used very widely, in my opinion. Then, in summary, when you have a severe ARDS patient, I suggest starting with a tidal volume of 6, optimizing PEEP to have the plateau pressure under 28, and the driving pressure, for sure, lower than 15. If you cannot achieve that, then you have to consider further reducing tidal volume and consider ECCO2R, if you have it. Now, if you can achieve your driving pressure lower than 15, you should look at pH and respiratory rate. If pH is high enough and respiratory rate is low enough, maybe you can stay here, or maybe not. But if it's not the case, you cannot maintain pH, or you have very high respiratory rate with a very high power related to mechanical ventilation, then again, you can probably consider ECCO for a more protective strategy. And the last situation, you have whatever you want with your 6 milliliter by kilo. Remember the data of Amato. Remember that if you have a lower driving pressure, you have a lower mortality, then maybe, even here, we should consider reducing tidal volume to decrease delta P, driving pressure, and again, there is maybe a place to consider ECCO. Thanks for your attention.
Thank you very much for a great exposition and also recommendation towards the end. If I may, we are running out of time. To invite John on stage and briefly respond to a suggestion that if we are not achieving the goals with standard therapy, what should we do if not a core?
All I can tell you is that was a very nice presentation. Very nice presentation, of which I certainly agree with almost all of it. I was just pointed out by Paolo Pelosi that the REST trial was just published yesterday in JAMA, and they concluded that it was not helpful. So that's no surprise to me because I knew the information from before. There is potential, definitely potential, to use this technology in the right way for the right people with the right indications. But for many people, depending on the time course of the development of their problems, etc., it's an aggressive form of therapy. And until we find a way to local anticoagulate so that the systemic anticoagulation is avoided, and yet the circuits do not clot and so on, I think it's just a little bit premature, just a little bit ahead of where it should be implemented into routine practice. The final thing is, I don't know, as somebody who investigates ventilator-induced lung injury, what numerical guidelines we can use. I do not believe a driving pressure of 15 is safe or a plateau pressure of 30 is dangerous. There are patients who have plateau pressures much higher than that, driving pressures that are higher than that, and they're doing just fine because their lungs are not vulnerable. We don't know the numerical numbers we should be aiming for, and so it's difficult to construct the guidelines in a rigid way. We have to look at the patient. Are they deteriorating? Do they have something that reducing CO2 would really help with?
Definitely, we have technical issues with the technique, but the rationale, the physiological rationale, before using very protective mechanical ventilation, for me is clear for the more severe patients. And I'm sure that we have to target on those patients, but definitely we have to improve the technique and to reduce the side effects. And to be very honest with you, we don't have ECCO in our unit because there are too many complications right now. And if we really need something, we use ECMO. But the rationale is here, then we have to go on with the technique, I think. Yes?
Thank you very much. We have experts in the room. Luciano Gattinoni was the first one.
I think the story of ECCO2R was started with Kolobov in 75, 76, exactly with the same goal. And we have now the REST trial. But what is very funny is that nobody speaks how much CO2 is removed. Because if you remove 20 or 30 milliliters per CO2, it's just ridiculous. You just add the complication without any goal. So there's people speaking about ECCO2R without ever seen a patient with extracorporeal removal. The first thing to be specified is how much is the CO2 removal, and how much has been changed, not only the tidal volume, but the frequency. So I think if you look at the REST trial, no? I was discussing the design of the REST trial at the beginning, and I always said the promoter that cannot work in this way, because you don't want to reach what is the aim. So the specification of this amount of CO2 removed from the membrane line, plus the amount of CO2 removed by mechanical ventilation is fundamental when you have to speak about this argument. If not, it's just speaking.
Totally agree, and this is also very important for the SUPERNOVA trial, because in the SUPERNOVA trial, the two techniques, the very low flow and the low flow techniques, were used. It was about 1/3 of very low flow technique and 2/3 of higher flow techniques, and definitely the only patient in whom it was possible to remove some CO2 were the one in the higher flow techniques. Then I totally agree, it's a key point. I don't know what you think.
I think Lisa said it very well. There are nuances to the use of these techniques. It's a wonderfully stimulating technique to think about for the proper indications personalized to the patient that you're looking at. I know that's an old theme, but you can't broadly say this is what we should do with this protocol in place. This is the point at which we do an extracorporeal CO2 removal, low flow or high flow. High flow gets rid of a lot more CO2 and has more potential, but there's also big problems. So I guess that's my weak response to that.
Thank you very much. I think we're getting to conclusion. We have time for one last question.
Yes, only let me give one comment, because I totally agree with Luciano, and I guess it's now time to go one step back and not forward. And as Luciano pointed out, you had one slide, Lise, and there was a blood flow range from 250 to 1 ml, 1 liter per minute. That's so different. That's like driving with an old car with a Ferrari. So we have so different effects if you eliminate 50 ml CO2 or 150 ml CO2. So this is, I guess, the first point we have to really keep in mind. And the second point, where I do not agree with you, you said that ECCO is less invasive. I guess ECCO is more invasive than ECMO with the current technology. In terms of putting a cannula, it's less invasive for sure. But if you look at the blood trauma you induce with our current technique we have, that's much higher than with high flow, because all these rotational blood pumps we have on the market, they are optimized for high blood flow rates, let's say 4, 5, 6 liter. And if you go down with them, you have a recirculation rate of 10 times in such a pump. And for sure, it's, I guess, now the time, it's better to go one step back, to optimize the technique and then do the trials once more. And if you look at the REST trials, in 202 patients, we had 10 patients with intracranial bleeding. So this is a matter of the technique, and we can overcome these problems, but it's not good to go for next trial. And we have also not, I guess it's not the best time to hear to the industry who's pushing it with 250 ml. Like, it's better first go one step back and optimize the technique.
And that's probably the reason why a lot of us don't use the currently available techniques for ECCO. Definitely, it's the point.
Thank you very much. We're running out of time. We've ended up to 30 minutes, but still 10 minutes delayed. I'm very sorry for that. And I think we've got into a nice conclusion. We need to keep thinking patient-centric. Thank you very much.